Episode of the task series today evening. So, under the aegis of Academy of Global Obstetrics and Gynecology, and she'll connect together, bringing this task webinar. So, task stands for Trending Ask Series, where trending topics are discussed. I'm pleased and honored to invite Dr. Niranjan Chavan, sir. Sir is the Unit Chief, LTM Medical College and Hospital, Zion Hospital, Treasurer Foxy, Vice President MOGS, and sir is as various publications to its credit. I welcome you, sir. I welcome you to invite the chief guest and guest of honor today, sir.
Thank you, Dr. Stalin. We go ahead with our trending task series number 9, and we have wonderful topics today. And I would request you to please call upon the slide of our chief guest, none other than the ever young, the southern lady, the southern, I can say, nothing less than a film star, and she always rocks. She's been there for more than 3.5 decades with us in obstetrics and field of gynecology, having her own practice in Trichy and Chennai, having her own center. She has done a wonderful job when she was the past vice president of Foxy, and she is also the emeritus professor. I would like to invite Dr. Jayam Kannan madam to be our chief guest. Thank you, madam, for gracing the occasion and being there with us. Please, we request you to please throw some light on today's program, and welcome, madam.
Very much, Niranjan. I am always part of any program of Niranjan and Komal Chavan. I am very happy that Komal Chavan has become the best committee chair of this year. And regarding this program, about the recent upcoming topics, every topic in gynecology is very, very important so far as the woman goes. Couple of months ago, I was talking on vulvovaginitis. But when a woman who gets the irritation, then only she knows how important is that topic. So probably topics like fibroid, endometriosis, and the Parul Kotadawala's very interesting topic of abnormal uterine bleeding. All these things are all very important topics, but when the woman comes in particular, every problem of her becomes very, very important. And I've been asked to speak on the gynecological challenges of a disabled girl. When I went through the topic, I did not get any material in the textbooks of gynecology, whereas I get wonderful materials from social obstetrics. I'm very sure Niranjan Chavan, with his Academy of this Global Obstetrics and Gynecology, he will throw lights on these sort of topics which are never touched by a general gynecologist, thinking that, yes, disabled women go into the field of, they say, handicapped person dealt with by neuropsychiatrists, neurologists, orthopedicians, and others. But just imagine a woman who has had a cut injury and she has to tackle her menstruation every month. That becomes a very, very important topic. So I'm very sure that Niranjan, who is inviting people from all over the world, are going to touch upon all these topics which are going to be very, very important. And I'm very happy that I'm sharing this session with Rishma Pai, with whom I have got 50% of my years of experience. Niranjan, I have finished 51 years of my obstetrics and gynecological career, and entering the 52nd year. Probably some of you may be only less than that age of mine, but I'm very happy that I'm asked to be chairing a session with recent trends. Thank you very much. Have a great day. Have a great time. Let me learn something new from all of you. I'll be there in this program. Thank you.
Thank you. Thank you, madam, for those wonderful words which you have encouraged us, all of us. We never ever grow old, and always we are practicing. Obstetrician and gynecologist are the ones which give birth to life, and the thing continues. So generation on generation, and since you are in practice for 51 years, I think grandmothers have been delivered by you, and their grandchildren are coming now to deliver with you. So it's an amazing phenomena. Right now I am in the third generation. You have already reached the fifth generation, and I hope I reach there also with all of us colleagues there. Thank you, madam, for being there with us. Now I would like to welcome our guest of honor, and we have Dr. Parul Kothadawala from Ahmedabad, and he is a director and surgeon endoscopic of the VS Hospital, and also the Kothadawala Women's Clinic. He is always at the helm of affairs whenever you talk about endoscopy, about infertility, being there as a managing committee member, and it's a great honor that he is there with us today. Can you hear me?
Yes, sir. Yes, sir, you are audible, sir.
Yes. I would request Dr. Parul sir to please say a few words.
Well, thank you, Niranjan, for such high words for me. As Dr. Jayam mentioned, Niranjan and Komal, I had the opportunity to be in the program today itself in both of their leadership. The first one was ISOPAR program, and from there I joined this one. So I still remember the many years back when Niranjan and Komal had come to Ahmedabad during B&B examinations.
Oh.
Must be 20 years back or more maybe.
Yes.
So, but today's deliberations are all on fertility, and it is very popular area for OBGYN. If you ask any youngster that what would you like to focus upon, I'm sure more than 50% tell me fertility. And that is why when I was a student, when somebody asked me, what is your interest area, I would say something different, and immediately the question would come, not infertility. I said, everyone wants to go for fertility. Let me work on something else. But indirectly through endoscopy, I am also touching upon fertility quite a lot. And I am sure that I'll add to my knowledge of non-surgical part of fertility, which is going to be deliberated today. I wish this program all success. I see Dr. Pankaj here, and he has been a backbone of IFS for fertility work. Yes. So,
yes,
wish you all a very good webinar. Yeah.
I agree with you, Parul, that even though you are an endoscopic surgeon and a general obstetrician, we still touch upon infertility. There are patients which come back to us, and it's a beautiful subject. You know, the way things happen and the different parameters which we see. I think no one can miss out infertility, even though he practices any other part. But endoscopy and infertility is very well connected, and it's really nice of you to share your memories with us, and same here it goes with us. Thank you so much, Parul, for giving your valuable time. And you're not just going to be sitting there as an armchair chairperson. We want your expert opinion. Madam is there, and well, she's the diva of infertility. What can I ask more today? You know, if she says yes and she comes for my program, and the another the northern India giant, I can say, Colonel Talwar, Pankaj sir, and it's amazing that both of them have come here today. I welcome now our next guest of honor, and that's none other than Ranjana Khanna. Ranjana Khanna, madam, is very golden lady with a warm heart, the way she has organized, I have seen with my own eyes, and Komal has also seen. She is actually a founder president of Prayagraj, earthwisely known as Allahabad, and of Isoparp of the Allahabad Obstetric Gynec Society. And what a wonderful place! You have Ganga, Saraswati, and Jamuna meeting at that Prayagraj, and there is a Kumbh Mela, and it was so beautiful place that we had a lovely time with her when we went there. And we, madam, miss also the bad obstetric history which you had done the trilogy in Delhi during your vice presidential year, and it was so rocking. And madam, the way you smile and the personality you have, I think from one corner of the year to another, I think there is no other person who can smile the way you are. And we tire our muscles, our facial muscles can't take it. But I don't know, you are such a wonderful family, and your son is an orthopedic surgeon, your daughter-in-law being there in an infertility, and sir is being there. Welcome, madam. What more can I introduce you? I request you to please put forward your words, and then we move ahead.
Yeah. A very good evening. And at the outset, I would like to thank you, Dr. Niranjan Chavan, for this invite. And it gives me great pleasure to be the guest of honor along with Dr. Parul Koddawala. In fact, in the last webinar, only just a few days back, Dr. Parul was the main speaker, and I think I exhausted him with the huge topic that I gave him: delivery of a patient with placenta previa, adherent and non-adherent. So Dr. Parul was amazed that the huge topic was given to him. And it gives me great pleasure to be the guest of honor along with you, Dr. Parul, and of course with Dr. Jayam as the chief guest. One of the speakers of the day, the first one, is my most favorite, Dr. Rishma Pai. And she is an excellent orator, and who would know it better than me? Because I was one of the vice presidents when in 2017 when Dr. Rishma was the president of Foxy. And I tell you, she is a near perfect persona. I've never seen a person who organizes events and everything with meticulous perfection. And that is one thing, Rishma, I have learned from you. And that is to do things very meticulously. I really admire you for that. And your topic is wonderful, challenge of poor responders. Looking forward to hearing that. And the other speaker is Dr. Pankaj Talwar. I have heard so much about you and the Birla Infertility Centers, and a lot I have heard about you. My daughter-in-law has also done fellowship in IVF, which is currently in Delhi. And she's the one who talks so much about you. So, and you are going to take up a very nice topic on sperm selection in IVF. So, looking forward to this. And of course, Niranjan, we are not just going to sit there, we are going to speak at the end also. Because that is one thing you told me in the beginning only, that you have to sit there, hear everything. So we are there, and I wish this program a great success.
Thank you, madam. Thank you. Well, thank you so much, madam, for your presence. Now we move ahead with our first speaker, and I call upon Dr. Rishma Pai, madam. She is the assistant treasurer of the International Fertility Federation Society, past president of our Mumbai Obstetric Gynec Society, the IAG, SR, and Foxy. I think she has donned all the caps which no one else has got up till now, and it's amazing that, madam, you have got such a wonderful personality, and you are practicing at Lilavati, at Jaslok Hospital, a director at Bloom IVF Center, and also have received FRCOG, has got many awards, I can say, and that's what you have taken and representing India at the international level. It's amazing to be with you today. And this is a Diwali offer. This is the Diwali bumper offer, and I could not get anyone except you. Are the right person to be here, madam. Please, the floor is yours. Please go ahead. We are waiting for you to hear your lecture.
Thank you. First of all, I have to stop laughing. Thank you. I mean, the praise is heartwarming, but at the same time embarrassing. I think all the people I am so fond of are here today, and that's why they are seeing me through rose-colored glasses, and I'm getting all these wonderful compliments, which I'm not sure I deserve. But thank you so much. It's so wonderful. Like you said, it's a Diwali special for me too, to be with all of you this evening. So thank you very much. And like everyone else, I cannot say no to Niranjan. And so though I've been really busy, I am here today. And of course, the subject is something very close to my heart. And so that makes it even more special. Can you all see my screen? Can my screen be seen?
Yeah.
Yeah?
Yes, madam.
Perfect. So I'm going to just go and dive right into the topic. So today we are going to be speaking on the challenge of the poor responders. And truly, it is a huge challenge, as you will see as we go along. Let me begin by saying that you can't spell challenge without change. If you're going to rise to the challenge, you have to be prepared to change. And I think as obstetricians and gynecologists, we are constantly ready to change because there's so much happening in our field. In every aspect of our field, dramatic changes are taking place in how we manage patients. So what really is premature ovarian insufficiency? It's a complex, relatively understood entity, and it has a myriad of different etiologies and multi-system sequelae that stem basically from the premature deprivation of ovarian sex hormones. So many different terms are used to describe the same problem, whether it's premature ovarian insufficiency, poor responders, diminished ovarian reserve, premature ovarian aging, all really trying to explain the same problem in different ways. All of us know that the field of assisted reproduction, we have made huge steps in this area. But even today, one of the most fundamental steps to reach success is related to the number of eggs that we can get. So in poor responders, unfortunately, we get less number of eggs, less embryos, and obviously lower pregnancy rate. And this is a rate limiting step really. Today, we see that the incidence of poor responders is literally increasing, and we've all experienced it in our practice, and may range anywhere between 9 to 24%. And unfortunately, the pregnancy outcomes in these patients are really poor. So what are the broad causes of this poor ovarian reserve? Of course, each woman is going to face a physiological decline of a follicular heritage over a period of time, especially after the age of 37. But some other common causes are obviously ovarian surgery, like the one you can see on the screen for an endometrioma. Importantly, we don't often consider genetic defects, and Fragile X syndrome is one such common problem. I'll just touch upon it in a bit. Of course, if a lady is going through chemotherapy or radiotherapy, has an autoimmune dysfunction, is a chronic smoker, has had uterine artery embolization for fibroids in the past, all of these may have an impact upon her ovarian reserve. And the reason I'm just touching upon Fragile X syndrome is because not many people know about it or look for it in a patient who has poor ovarian reserve. So remember that 20% of these women who develop Fragile X associated primary ovarian insufficiency. So a large number of this group will have premature ovarian insufficiency. They also have, obviously, because of declining hormones, they have menstrual dysfunction, they have infertility, and they might have dizygotic twinning. And because of low estrogens, bone health is impaired. They also have neuropsychiatric issues, and you should look out for them. There may be tremors or ataxias, anxiety, depression, sleep disturbances. So when you see all this, think of Fragile X, and you can start sort of checking for it. And awareness of these risks and correlation of the manifestations will help us diagnose this condition and offer them certain therapies which will be beneficial. Another area which is often neglected is the prevalence of autoimmune disease in this group of patients. You'll be surprised to hear that 40% of these patients had at least one confirmed autoimmune disease, whether it was Hashimoto's disease, SLE, rheumatoid arthritis, psoriasis, Crohn's disease. So some autoimmune connection is often there. So when you see an unexpected poor ovarian response person, make sure you keep a lookout for autoimmune conditions as well. So how do we really diagnose or come to a conclusion that this girl has poor ovarian reserve? Of course, you see her age, you see her menstrual pattern, do a sonography, count the antral follicles, and of course, see the ovarian volume. And typically, we rely more and more on anti-Mullerian hormone as a simple blood test. I typically don't do day 2, day 3 FSH, LH anymore, inhibin very, very rarely. And the dynamic tests like the clomiphene challenge test or the GnRH agonist stimulation test, I think really are not being done by anyone, and really we don't have much information or knowledge or experience with them. So typically, remember, age is the single most important factor, because age correlates not only with the number of eggs you're going to get, the number of embryos you're going to get, but also with the clinical pregnancy rates. Whereas all your other parameters like antral follicle count or anti-Mullerian hormone test, all of them correlate just with the egg and embryo number, not actually with the pregnancy rate of that patient. So age is really one of the most crucial indicators. Once we found all this, how do you define that this girl really is a poor ovarian response person? So at least 2 out of the 3 criteria, if she fulfills of the Bologna criteria, then we can classify her as a patient with poor ovarian response. Either she's had a previous episode of poor ovarian response, abnormal ovarian reserve test, or she's more than 40 years of age. However, this Bologna criteria was established in 2011, and since then faced a lot of criticism. Why the age of 40? Supposing she is a poor responder, what are you going to do for her? And so a lot of criticism gave way, obviously, to better classification systems. And so we have gradually moved away from the Bologna criteria and come to the Poseidon criteria, which is the patient-oriented strategies encompassing individualized oocyte number. And here we have the patients being divided into 4 different groups. And this is really important because entire prognosis and management plans are now based on the Poseidon criteria. So the group 1 is a young patient, less than 35 years of age. Tests are okay, AMH more than 1.2, AFC more than 5, yet when you do ovarian stimulation, the response is poor. Poseidon group 2 is a little older group, more than 35 years, normal tests, but a poor response. The actual poor responders are the group 3 and 4. Group 3 is less than 35 years, low AMH, low AFC, and group 4 is more than 35 years, low AMH, low AFC. So once you classify patients into this group, then it becomes very easy to manage them subsequently. So in this poor responder group, what kind of ovarian stimulation should we do? Should we keep giving them a very high dose of gonadotropins, whip the ovaries and make it produce eggs? There are many, many studies, including the Cochrane review fairly recently, which said that the evidence does not provide a clear justification for adjusting the standard dose of 150 units. So they stick to 150, though there are other studies, and typically most of us also stick to a dose of maximum 300 units of the gonadotropin in this group of patients. Because you cannot, how much ever dose you give, you cannot create eggs or follicles out of nothing. Since the antral follicles are low, you can only stimulate the existing follicles. You cannot create follicles in vivo, sorry. And so, a lot of good studies, and this particular study came in just last year, comparing gonadotropin, long-acting corifoliotropin alpha. Unfortunately, we don't have that in India right now, but I hope it will be here soon, because particularly in this group of patients, it seems to work very well. in this study where they were giving good doses of HMG and the patients got a very poor response and did not get pregnancy, when they started with 150 micrograms of long-acting cortifolitropin alpha and then gave small doses of HMG with it, the patient started to produce eggs, gave a better response, and got a pregnancy rate of 24% per ovum retrieval. And so this particular molecule works very well in poor responders. Even the Cochrane review has studied something which many people often talk about, that as it is, you're going to get 1 or 2 or 3 eggs in these patients. Why give gonadotropins and waste money? Why not give oral ovulogens like clomiphene or letrozole, give a few gonadotropins extra and produce the same 1 or 2 eggs? And there is definitely a positive to it, that the cost is low, less amount of gonadotropins are used. But there is also a negative, that there is a higher risk of cancellation and reduction in the number of eggs that are actually retrieved. So there is definitely a role for clomiphene and or letrozole with gonadotropins, but the results are little poorer than with gonadotropins alone. What about the down regulation? Should we use analog? Should we use antagonist? What should we do? And this was a very nice study in 2019 where they put the patients into 3 groups, using GnRH antagonist, using long down regulation with GnRH analog, and using short GnRH agonist protocols. And they found that typically the group which used antagonists for down regulation, they had more embryos being produced and cryopreserved. And the long down regulation needed more gonadotropin because of extra suppression. But overall, the outcomes, the pregnancy rates, the live birth rates were very similar. So you can choose to use whichever method of down regulation and expect to get reasonable results. However, Sunkara came out a few years ago with a really nice study where she said that the long GnRH agonist protocol increased the number of mature oocytes by 1. And just 1 more egg in this poor responder group actually increases pregnancy rate by 5%. And this is a fantastic increase in this group, which has a very poor pregnancy outcome anyway. So you can see in a girl, for example, who's 38 to 39 years, she gets 3 eggs instead of 2 using long GnRH analog protocol. And her pregnancy rate increases from 8 to 12%. So significant increase with just 1 egg. And that's why there may be something for long GnRH analog. Of course, microdose flare-up protocols have been used for many years in patients with poor ovarian responses. So small doses, 50 micrograms twice daily on cycle day 2, and then you start your gonadotropin stimulation on day 3, and fairly good responses are obtained. So all the options are open to us. And now we even have newer options. And these are amazing new options because they are radically different. And that is using progesterone-primed ovarian stimulation. So you start your gonadotropins on day 2 or 3 as usual. And whenever you're ready to start the antagonist, when the follicles are, for example, 13 or 14 millimeters, instead of that, you can start 10 milligrams medroxyprogesterone acetate orally. And it has been found in a comparative study that results are similar. So you can downregulate your patients with progesterone as effectively almost as with GnRH antagonist. You can also start this progesterone right from the beginning of the cycle. So you start gonadotropins daily from the 2nd or 3rd day, and you start your medroxyprogesterone 10 milligrams per day also from day 3, and you continue it till the trigger is given. And you can actually see reasonably good or equivalent pregnancy outcomes. Very rarely there could be a missed premature LH surge. So progesterone primed ovarian stimulation is now here to stay. For this particular group of people, the poor responders, we also have another protocol called the delayed start protocol, because in this group, there is a very high LH and FSH, and this tends to cause the follicles to grow asynchronously and have a premature luteinization. And so what you do is you prime the patient, you start her on estrogen in the previous cycle, Stop the estrogen, let her get her periods. Once she gets her period, you give her GnRH antagonist from day 2 to day 7. This reduces your FSH-LH, and then you start the normal gonadotropin stimulation. And when your follicle is 13, 14, start antagonist again. So you're giving antagonist twice actually in this cycle, but this causes synchronous growth and better oocyte recovery. So basically, like I said, we are now centering around the Poseidon criteria, and our stimulation protocols are also being centered around that. We are now focusing on what we call the FORT and FOI. The FORT is the pre-ovulatory follicle count on day of HCG divided by the antral follicle count. And the FOI is the number of oocytes which you actually retrieve divided by the antral follicle count. And, this actually can help classify patients who have the best ovarian sensitivity. This is the group 3, which is the young woman with a poor ovarian reserve. And this group of patients, what you have to do is adjust the gonadotropin dose. Just give them a higher dose and they will do better. Whereas the group which has poor sensitivity, group 2, which is the older woman with normal ovarian reserve, you actually need to change your protocol around. Just increasing dose may not help. So update on the management now based on this Poseidon criteria. So when we expect the patient to be a poor responder, which means group 3 and 4, already you know that they have a poor ovarian reserve tests, you know that they're going to be poor responders, you automatically start preparing for that right from the beginning. And so in this group, the group 3 and 4 Poseidon, you can give GnRH antagonist or analog. The results are the same. Don't give very high doses of gonadotropins, not more than 300 units. We spoke about that already. And in some cases, you might give a combination of oral plus gonadotropin therapy, and that will also give you good outcome. The difficult part is when you get an unexpected poor ovarian response, that is group 1 or 2. And this group of patients may have polymorphisms, single nucleotide polymorphisms in the receptor or genes of gonadotropins. And there could be a variant of the beta subunit of the LH gene may also require higher doses of stimulation. So in this group of patients, you have to start with at least 50 units more of gonadotropin. So though they are normal AMH AFC, they need higher dose of gonadotropins due to their presence possibly of polymorphisms. So give recombinant FSH in many of these patients, use agonist or antagonist, give a higher dose, like I said, at least 50 units higher dose. And in a very poor responder group, LH supplementation may have a role to play. So combination of FSH-LH may be better than FSH alone. What about add-ons, the adjuvants? This is very, very popular in poor responders. They get a huge cocktail of drugs to try to improve their ovarian reserve. And many, many studies have been done on it. And I'll just rush through 2 or 3 just to mention. Growth hormone is one. There have shown that growth hormone supplementation may increase clinical pregnancy rate, number of eggs available, etc. And however, it does not improve the live birth rate. So these are all very, very recent studies where growth hormone has been used. 7.5 to 12 IU have been used, starting from the down regulation cycle in a long protocol. So throughout that cycle, they're given, and still the results may or may not be beneficial. Similarly, transdermal testosterone using androgel can improve the responsiveness. The use of DHEAS may help by improving mitochondrial function and reducing the apoptosis of cumulus cells. So there's a possibility that they may have a beneficial role to play. And the LH supplementation, and again, extreme poor responders has seen to be beneficial, not in just borderline cases, but in moderate to severe poor ovarian responders. And so to put it all together, DHEA, coenzyme Q10, growth hormone, these seem to be the additives which work. Rest of the things do not seem to have a beneficial effect. But at this juncture, I'd like to say, don't be discouraged. It's often the last key in the bunch that opens the lock. And so what are the things we can do to improve outcomes? One thing we can do, and it's becoming increasingly popular, is luteal phase stimulation or double ovarian stimulation in this group of patients. it has been found that there are multiple 2 or 3 waves of follicular development in the ovary, not just the follicular phase. Even in the luteal phase, a cohort of eggs starts to grow. And when there was stimulation started in the luteal phase, it was found that these patients were giving equal number of eggs as they did in the follicular phase. And so you stimulate in the follicular phase, give it a gap, do your egg retrieval, wait for 2-3 days, start the stimulation again, and again in the same month, you can get eggs twice from the same patient, increasing the number of eggs. So duostim, as it's called, can be very comfortably done using GnRH antagonist for downregulation, GnRH agonist trigger, ICSI, and then you freeze the embryos. You can't obviously transfer them back in the same cycle, and then you start second stimulation. And you can see that the cumulative live birth per intention to treat increases from 7 to 15% with duostim. So quite a dramatic new approach to ovarian stimulation. Not only stimulating twice, even triggering twice or dual trigger in this group is shown to be helpful. So as it is, you give HCG, along with HCG, give small 0.1 to 0.2 milligrams GnRH analog as well. And you will see that you get higher number of eggs and mature oocytes and better pregnancy outcomes. In this group, also you can do highly individualized egg retrieval. Get the eggs out a little early at 16 to 18 instead of later, and you will get better results because you're preventing the premature luteinization. This is the only group of patients in which day 2 transfer may have a role to play. And you can transfer 3 or 4 eggs even. Everywhere else now they're recommending single embryo transfer. But in the very poor responder group, older patients, you can transfer higher number of eggs. And all of us are and have been doing for a long period of time oocyte cooling. So we do multiple cycles, accumulate a number of eggs and embryos, freeze them, make a pool of oocytes, and then the patient can be given fairly good chances by transferring back 1 or 2 embryos each time. And the cumulative success rate is very good. However, if everything fails, even today, many of these patients have to resort to egg donation. And you know that with egg donation, they will get excellent outcomes, as good as any young patient will have. So the last part and short part of my talk is about the newer things that have happened, because we know that when we are faced with a challenge, we have to look for a way, not for a way out. And so what are the new ways that are being looked upon to improve outcomes in this very difficult group of patients? One thing that came in about 2-3 years ago and has now become extremely popular is the injection of platelet-rich plasma into the ovary. And the patient's own PRP is isolated, it is activated, 5 ml is injected into each ovary, either under sonography or laparoscopy control. And it has been found that as early as 2 to 3 months later, you can actually see an increase in AMH, improvement in FSH, and the eggs begin to grow, and you'll get eggs in a patient who otherwise gave no oocytes or embryos at all. And there are many studies now reflecting on the improved pregnancy outcomes in this patient. And I just put one study, you don't have to go through it in detail, just to tell you that this PRP works in many different ways, because platelets carry more than 800 types of protein molecules, cytokines, hormones, and there are many biological active mediators which are released by this platelet, which include platelet-derived growth factor, transforming growth factor, fibroblast growth factor, insulin-like growth factor. There's more angiogenesis, anabolism, inflammation control, proliferation. So you can see that one PRP is working at many different levels, and patients who did not achieve pregnancy earlier have been able to achieve pregnancy after this therapy. Similarly, you can use autologous stem cell ovarian transplant called ASCOT. And these are bone marrow derived stem cells which were mobilized into the peripheral blood by giving GCSF. Again, something that we are doing routinely. And these cells in this particular study were delivered into the ovarian artery by intraarterial catheter. You can also inject stem cells into the ovary directly. And there was a significant improvement in the ovarian function, and more eggs and embryos could be produced from these patients. In vitro activation is a reality, though much more difficult, whereby under laparoscopic surgery, a piece of the ovary is removed and it is cut into strips and frozen. Whenever we want to use it, it is thawed, cut into small pieces, basically to disrupt the hippo signaling. Then it is cultured with AKT stimulators for 2 days. It is washed and then retransplanted back underneath the fallopian tube. And it was seen that in a short period of time, this ovarian tissue is actually activated and starts to grow and produces eggs. And they have been reported patients, you can see in 9 out of 20, they showed follicular growth, and 3 pregnancies were achieved out after transferring into 4 patients, in patients who were otherwise completely not able to become pregnant because of lack of oocyte retrieval. Then, of course, we have the mitochondrial energy transfer. All of us know that as the ovary ages, the eggs age, they have less number of mitochondria. And mitochondria are the energy factories of the cell. So when that reduces, you get poor fertilization rate, poor embryo development. And so many strategies have been employed to rejuvenate these ovaries, trying to do autologous mitochondrial transplantation. And this actually energizes the oocytes and may improve outcomes. And there are some studies from centers across the world where they have practiced this autologous germline mitochondrial energy transfer, the augment technique, and they have shown pregnancy rates as fantastic. Pregnancy rates earlier were as low as 5% or 1.3%, went up to 35 and 22% respectively after using this augment technique. And this is what they really did. The egg precursor cells were taken from a small biopsy from the ovary. They were cultured and frozen, and then mitochondria from these precursor cells were picked up and along with the sperm injected into the ovary, into the oocyte during ICSI. And so this mitochondria were infused into the oocyte, activated them in a way, and gave better pregnancy outcomes. And of course, this has been grabbing headlines. Scientists grow human eggs to full maturity in a lab. For the first time, eggs have been grown outside the human body from the earliest stage to full maturity. So if you can actually get eggs out at a very early stage before the patient is undergoing, for example, chemotherapy, and we can grow them to full maturity in the lab, then you will have a lot of control over that patient's fertility. So also artificial ovary, and these all headlines which came out in the newspapers in the West. And this paper was presented at one of the ESHRE conferences. I was there in 2018, and they said that actually you could create an artificial ovary, and you could create a scaffolding of that ovary, and you could actually transplant the patient's own eggs, which have been retrieved much earlier before she underwent chemotherapy or cancer therapy or oophorectomy for cancer, and then you can transplant those eggs back. So much of this research is being done for fertility preservation for cancer patients, but it is the same applications for patients who are losing their ovarian function for other reasons very early in their lives. And artificial ovary may become a reality in 5 or 10 years. And so very soon we will see this development happening. And so let me end by a very brief summary that poor responders have significantly lower clinical and live birth rates. Increasing the gonadotropin does not increase egg number, as the eggs cannot be created. Long GnRH protocol, microdose flare antagonist, all the protocols are equally good. You can, in this group, do an early embryo transfer on day 2 or 3. Adjuvants such as DHEAS, coenzyme Q10, and coenzyme Q10, DHEAS, all of them have been, growth hormone, have been shown to have some beneficial effects. Finally, oocyte donation may be the best option in a large group of these patients. Newer technologies such as PRP, stem cells, in vitro activation, augment may have a role to play in the future. And the last and very important guideline to everyone is that keep the patient conscious of her ovarian status, of her fertility. And if we feel that even a young girl has a lower AMH, lower AFC, then advise for egg, embryo, or ovarian cryopreservation for future fertility preservation. I always say, out of difficulties grow miracles. And I had the privilege of meeting one such miracle, Lucy Brown, the first IVF baby in the world. Met her at one of the American Society conferences 2 years ago. And of course, it was a privilege to get a picture with her, as I had the privilege also of meeting this man, Sir Edwards, who actually did that case, the first IVF baby of the world. So that's a very young Rishikesh and me with Sir Edwards himself. Thank you. Thank you very much.
Thank you, Reshma. It was a wonderful lecture, and so much recent advances you have done. Especially you have talked about all the formulas which are there, the autologous methods which are there, and really the challenge of poor responders is going to be very easy now. I call upon our esteemed guest of honors to give their expert comments. Dr. Ranjana Madam and Parul Sir.
What to say, Dr. Rishma has given such an exhaustive and a complete talk that today we have benefited a lot. And I can say that, Rishma, you have brought new insights into this problem. And though I'm basically not an IVF person, but still I'm doing IUI and all the other procedures. And I think this talk was wonderful, wonderfully complete, if I may say so.
Thank you so much.
Thank you, madam. Pankaj, are you there? You can have your expert comments with madam's lecture.
No, how can somebody comment on madam's lecture? This was just amazing, as always. Thank you so much. Lovely lecture, ma'am.
Thank you, Pankaj.
Yes.
Thanks a lot. I think we can.
Thank you, madam. I would like to tell you that Bloom IVF Academy has just been started 1 month ago. The directors of are Dr. Rishikesh Pai, Dr. Reshma Pai, Nandita Palchetkar. If you are setting up an ART lab, if you are going ahead and doing your future courses in IVF, please be free. It is available online. You can get in touch with madam. She is always warm-hearted to explain and get you on board. And it's a really amazing field of infertility. I remember when I just passed my MD, my mom was a DGO, DFP and DPH. She did from St. GS Medical College, and she used to feel so proud of me that whenever the patients used to come, she used to make me sit besides her and tell, ये मेरे से भी ज़्यादा पढ़ा लिखा है. और and madam, in infertility, infertility in Marathi we call Vandatva. So I was not aware of this word Vandatva, but really she used to practice, as Ranjana madam said, at the level of IUI and all, and see what has happened. So much courses have come, so much technology has gone ahead, and it's really amazing. It's not more a challenge now. So you all are welcome. And madam, I want to say we have got more than 2,500 delegates who have logged in, registered. So I am sure this is going to be very, very helpful to all of us, and especially the delegates who have joined not only from India but from abroad, Southeast Asian countries, Indonesia, Afghanistan, Nepal, and even China. And some of them are also from European and African countries. So thank you, madam, and you can be free, and you can get in touch with Dr. Reshma Pai, madam. She is available, or you can get in touch with me. Thank you so much, madam, for being with us.
Thanks a lot.
Now I call upon another great teacher of teachers. He is an amazing person, Pankaj Talwar. I met sir in 2016, and obviously we had interacted before also, but we were together for the gynae oncology workshop, which was conducted by Dr. Rishikesh Pai, Reshma Pai madam, and it was such a wonderful honor for all of us to being there. The first time in India, IFFS had done this wonderful 5 days infertility workshop, and sir was there. He was a part of the whole program, and then the journey continues, and we can see now he is doing wonderful. He left the army now. He is already He was the secretary of IFS. Now he is the vice president of IFS. IFS is the Indian Fertility Society. He is the head of Birla Fertility and IVF. He has got many courses, course 1, course 2, course 3. We will talk about that later. He has received Lifetime Achievement Award from the IFS Society, has edited many books, has got his own research, and even I call him up, and if there are patients in Delhi, if I had to refer, or they are absolutely from the army background, they are usually welcomed by sir, and of course the general population. I hand over the mic to sir now to go ahead with a very interesting and a very different topic. I had a discussion with sir, and he said that Niranjan, this is the in vogue thing, and something about selection of sperm. How do you select? We have got so many problems. We have got such a technology, and I would love to speak on that. And sir, we are all ready to hear from you. The mic is yours. Please go ahead. Thank you, sir.
Thank you, Niranjan. Is my screen visible to all? Can
Yes,
everyone see my screen?
Yes.
Yes, it is.
So much. I'm in the hospital. Sometimes, the signal pops in, pops out. In case something happens, just bear with me. Well, thank you so much for inviting me here, Dr. Jim, Dr. Parul, Dr. Ranjana. Thank you so much for saying kind words about me. Niranjan, is always a delight, coming for your meetings. They are just fantastic. Thank you so much for inviting me again. Dr. Rishma, is always, it's a big challenge. It takes me nearly 30 years. I told her before also that when anyone has to speak after her, it needs courage and training in Indian Army for 30 years to be here today. I have to hold my breath and hold on to my courage and then come on the screen. She's always a very kind-hearted person and always encouraging her juniors. Thank you so much, ma'am. It was a wonderful talk. Without much of ado, and greetings to all my seniors here, and I'll start my talk. That's about the sperm selection in ART, what's new. The topic is pretty recent one. My screen is not moving. Yeah. Hang on my screen. So fine. So when we think about infertility, we had a long, lovely lecture by Dr. Rishma Pai, and we spoke about various protocols. We do so much for a woman, and we are trying to generate such beautiful golden eggs. That's the aim of any IVF cycle. And for that, we have got such lovely laboratories, incubators. We send crores on embryo culture. Incubators, microscopes, big laboratories. We spend crores on setting up the laboratories, primarily to look after the women. But when it comes to men, we have the small plastic bottles costing 10, 15 rupees, 30 rupees, and few drops of semen. Things are pretty good. We see them under a microscope, but in the end, the male doesn't have much therapeutic measures to record his fertility parameters as compared to a female, and things are pretty okay. What all we can do. I'll take you towards this lovely picture where somebody's trying to make a cocktail here. And in case you look at this cocktail, when they mix various things, one good thing I learned from them, they say that we have to shake it only 14 times and not 15 times or 13 times, because 14 times is a bit much more and 13 times is a bit low. Same thing happens with the men when you prepare a semen sample. And what you find here is that we use a centrifuge machine here, like we do use a cocktail shaker, maybe Boston or a French one. So we use a centrifuge machine to make the good semen sample. So an objective sperm selection can lead to increased pregnancy rate and decreased abortion rate. That's our aim. That's our aim of moving forward. I have with me around 18 minutes from now. I have to speak for you, speak to you for around 18 to 20 minutes. And whatever I'll talk to you, we'll be having a lot of daily practice points, day-to-day application, and they should be simple to perform. By no means I'll go into big scientific data. By no means we'll learn so much that we become cerebral heavy, have an edema, and then fall down like an ugly demon. What I won't cover would be the specific procedures and protocols and methodologies. I'll give you an overview about what we are doing for the men now. I'll be drawing my courage from this Cochrane review, which came in year 2019. There are multiple papers which are available to us, but I'll be focusing more on the Cochrane review. To select a good sperm, we are normally banking upon this double density gradient media, which we use for doing an IUI, and similar ones we use for IVF. We are hopeful then when we are doing double density method, we are able to get a good for 450 or 78 BC, they call it. The battle between Spartans and the battle between Athens, which Spartans won. So this is a very lovely picture, but a hateful picture. Here they say that any boy who was born in Sparta was not of good quality. They call it a good quality, who had some deformity, was thrown off the hill. So they could make good warriors to win the war. That's the way somehow we are working on various technology to select good quality sperm. Okay, so look at this picture. This picture I have taken from an internet article. You find that as they are going up, there are a lot of hindrances which come in its way, which collect the sperms of good quality, and only the good ones are able to move up. The rest all ones are decimated. So out of millions of sperms which are deposited, only few are able to reach the fallopian tube, and out of them only 1 or 2 are able to fertilize. And they are the ones who have good morphology, who have got DNA integrity, and they are actually good quality sperms. So around 500 reach the ampulla, and only 1 is able to fertilize the egg. So the sperms are being deposited, and when they're moving up, they are facing multiple challenges, multiple hindrances, obstacles, and they go through various structural, fluidic, ionic, and molecular environments, and only good ones are able to move up. And whatever I'm going to talk to you today, the newer advances are based upon internal milieu of the woman per se. Natural sperm selection occurs how? It occurs on basis of pH. The vaginal pH is acidic, the semen pH is alkaline. So how, when the sperms start moving, they are exposed to the change in the pH, change in the temperature, mucus plug, immune response, and chemotaxis. All these things are going to oligospermia or mild, moderate oligospermia, then sperm selection becomes even more difficult. How do we carry out an exclusive sperm selection? Because look at the generations of evolution. We find that initially we were trying to find or locate a good sperm by doing microscopy, we were subjecting them to their density, that is the weight, speed, and morphology. And as these sperms, we apply these techniques, we also found that we can do something like a hyaluronate binding assays. We know that eggs have got all the OCC complexes they've got, they are very rich in hyaluronate. And sperms have got hyaluronate receptors. They're called pH 20 and acrosin receptors. The sperms which can go and bind with an egg, they should be having these pH 20 receptors. And they are the ones which have normal DNA and normal morphology also. Then we went one step ahead. We began with XC, came to MC. And here we could magnify the sperm and catch a good quality sperm and carry out IVF or ICSI. Then we had multiple obstacle courses, and we were doing something called microfluidics, where we made the sperms move in small channels. Small laminar channels we created in a plastic kit, small plastic plate, and that was called microfluidics. We were not tired, came up with a new technique called magnetic sperm separation, in which we were banking upon these sperms binding to a small magnet, and then they were selected on basis of their magnetic charge. The latest one in the market, the new kid in the town, is called zeta potential, where you bank upon the negative charge on the sperm and bank upon that negative charge being attracted towards a positive charge. And that's the way we use polycarbonate filters, or we use some barricades, and we select good quality sperms. Now, these are a few methods which we have. We can see density, surface charge, morphological characteristics, and a lot of them are there. So what I will bring you here, the take-home message is that we were trying to select a good quality sperm, and the option which we had always with us was a double density centrifugation method. Like we wash our clothes, we use a centrifuge machine and get good quality sperms. But now we are moving one step ahead. And these are the techniques which are available to us. And I'm going to do a review of literature of which technique is better. Do the sperms use heat sensors? We know that sperms come from a lower temperature. So they always move towards higher temperature. And in case they can move better towards a higher temperature, they are good quality sperms. This is one of the concepts, like a missile which is fired, and it follows then a target which is warm. That's called warm guided missiles. The sperms are moving towards a warmer perspective, but they are cold and they want heat. So they move towards the areas which are warmer. And a sperm which has got more capacity to move towards a warmer egg or warmer milieu, they are good quality sperms. So we have got chemotaxis, we have got thermal taxis, and we've got a lot of other methods by which sperms they try to find an egg. Probably they're able to smell an egg, or they are moved towards certain chemotactic factors. This is microfluidics, which we are using nowadays. Microfluidics has become a very, very basic investigation. And I think we use it in around 40 to 50% of our cases, they need microfluidics. We are moving further. And then nowadays we are applying magnetic beads, magnetic carriers to select our sperms. And that's the brief background of the talk. What we find is that nowadays the sperms are becoming weaker. They are fatter. They are tired. They've got a bad morphology. And this occurs more commonly in the men who are fond of nicotine, smoking. James Bond is a person of past nowadays. Drinking, smoking, cheers, midnight. Even women do it. Excessive cycling, sauna bathing, and a lot of other things. Power games, health drinks in the gym, taking sauna, mobile telephony, eating like me, I say. We all eat like him. Gaining weight, being a couch potato, mobile telephony in our pockets, and then always worry, fear, anger, sadness, self-esteem will lead to reactive oxygen species generation, and that lead to oxidative stress and infertility. So one thing we have learned is that there is high level of ROS found in the body, and they can lead to decreased sperm motility, viability, DNA integrity, and increase mitochondrial defects. They'll have lower in vitro fertilization rates, poor implantation, and early pregnancy loss. So let's see what all we can do to select good quality sperms. That's how to go beyond centrifugation, how to go beyond using double density gradient methods. And one method is that nowadays we are trying to avoid centrifugation. Just picking up the sperms by simple swim up by microfluidics or by just the migration techniques and using them for ICSI. Our aim is to choose few good sperms. We are not bothered with large number of sperms now because we are doing ICSI in majority of cases. The sample to be selected, how to select the sperms, it all depends upon the basic semen parameters. But we should try not to centrifuge. That will be my second take-home message to you. All of us who are doing some sort of IVF work, now we avoid centrifugation. This is one point I want to put across here, because by that we can have better quality sperms coming to us. Though there are indications of doing everything, we do centrifuge, but depends upon the initial presenting features. So non-centrifugation based methods are the better methods. The newer options. Let's see the buzz in the market. What's happening in the market? What all is happening globally? A lot of things are happening. What Dr. Dishma brought out very beautifully. I just add on to the male factor. There are very nice article from HFE and multiple bodies all across the world. They gave us a consensus statement about add-ons. They said we are having a big IVF add-on racket, and we are pushing women and men towards needless extra. Many randomized trials, and same thing Cochrane also says. Patient expectations, market forces, online information are driving us towards picking up newer technologies by which we separate our sperms. Sperm selection in male infertility. There are multiple articles, multiple papers are available, but one thing is for sure that we are adding antioxidants, we are adding newer techniques. Nearly 3/4 of all the men are undergoing some sort of treatment. Traffic light concept by HFEA, they says whenever we do is pick up a technology, that should be either green or amber or red, meaning we already know. So I would like to say that when you pick up a technology for sperm separation, that should be ideally green or maybe amber. Red technologies we should be now discarding. There are 10 techniques which we follow. I have not used all the techniques, but majority I have used. We have birefringence, which we use along with the ICSI, and we have surface charge selection, which means that here we are carrying out zeta potential separation. Surface charge selection means that we have to know that any mature sperm will have a negative charge. जो भी sperm अच्छा है, which has got good DNA, good morphology, will have a negative charge. The negative the charge, healthier is the sperm. So we just take the tube, rub like this, that creates a positive charge. And then the negative sperms will stick to the wall of the tube and they can be separated. That is called separation by zeta potential. Now what they are doing is that we agree that this is good technology, but nowadays they're putting small filters. They're putting polycarbonate filters, and sperms have to go through those filters. They have created one more hindrance for the normal morphology and normal DNA. So once you put those electrophoretic devices with filters, you're able to select better sperms. That's the way they do it. They put such polycarbonate membranes. So sperms, they move from negative to positive side, and what will get stuck to that plate will be a better quality sperm. Under research, this is still under research, but as per Cochrane, this is the finest method we can use for sperm separation, and that may be the right method for the future. Sperm apoptosis. Any sperm which opens up and the inner sperm membranes come in open, they express phosphatidylserine. It's a glycoprotein which contains phosphate and serine. So when they open up, they attract annexin. Annexin is a complementary protein which we have in the laboratories. So we put with annexin small iron beads. So annexin and iron beads will go and stick with the sperms which are open, which are damaged. And then we separate them by using a magnetic beads put outside our test tube. This technique came up in our country. I've used it for couple of say 15-20 cases. It's a good technique, but somehow again it is going off the hook and it is not easily available. It is called magnetic sperm separation, and it works on the magnetic properties fertilized in. And a sperm which has got good pH 20 receptors will only go and bind. So there's a natural way of sperm selection in vitro. So for that, we use small plates which are binded with hyaluronic acid, and the sperms which go and bind with these micro dots, we are selecting them and carrying out ICSI. The technique is called PIXI, and it works upon hyaluronan binding or small microdots which contains hyaluronan, and then we pick up the sperm from these microdots and carry out ICSI. This technique came up in a very big way, and we all used it. I think we would have done around 400-500 cases with PIXI, and this was around 7-8 years back. But now this technique is also gone off. Then came a new media which contains hyaluronan, and this media is coming from a company called Origio, and is called sperm flow. We use it for ICSI. So multiple techniques, multiple methods of sperm selection are there. A good thing which came was microfluidics. Here we use these small micro chambers and plates which will make the sperms move in small microfluidic chambers. As you can see, there are 4 wells, and they move with the pressure gradient, and they move through these small micro channels, and only good quality samples or sperms will be able to reach the other well. It's a very good method. We create chaos, and then we use a nascent sample, and then we allow them to go with some pressure head under some pressure, and they move toward these micro channels. And we also have a method that is sperm which is not a good sperm that will keep moving straight, but a sperm which is a healthy sperm which always move left and right. That's part of capacitation. So a good quality sperm will always move towards right or left and go to a well which is lying at a distance. But a bad quality sperm will always keep moving straight ahead and go to the collecting jar, collecting well, and there are bad quality sperms. So this is microfluidics we are using very frequently, and this is actually the future of seminology in the coming few years. I'm sure that we all are using it day in, day out, and in coming few days, I think, and we have microfluidics for IUI also, where you can prepare a sample without even spinning it. The advantage is that we use microlaminar flow. We don't spin. There is no centrifugation, and everything is sperms. They move in a laminar flow, and then they collect. As you can see, they go up in a well, and they collect somewhere, and all the bad sperms go to a different well. All WBCs and pus cells, they get collected in a different well. That's one technique. Around 7-8 years back, a new technique came. Big way, sperm birefringence, where they use some sort of lens and ICSI. It works on the principle that sperm has got protein filaments, and when the light will hit them at a particular angle, they'll birefringe, they'll shine. And any sperm which is shining better, that can be selected and we can do ICSI with that. So here we use polarized light microscopy. The sperm birefringes, more it is, better it is. So we are selecting sperms by their glow or birefringes and then carrying out ICSI for them. This technique came up with a big confidence boosting measure, but somehow it didn't catch on. That's the way sperm had birefringes worked, but it's gone out of vogue now. Then came IMSI and ICSI. ICSI we know that we look at a sperm at a magnification of say 300x or 200x, but that wasn't enough. The technique came from Israel, which magnified the sperm to 6,000 times. And by this particular technique, we are able to select good quality sperms, which have got good DNA and good acrosome. As you can see here, the top image is of ICSI and the lower image is of IMSI. It was a great confidence boosting measure, and we thought that we're going to do very, very well. In fact, I think Dr. Pai reported the first IMSI baby in the country also. So, but gradually IMSI is now no longer recommended, it's gone out of vogue. We are not using IMSI anymore. ICSI we are still using. So IMSI have told you that could magnify better and we were able to collect a good quality sperm. Understanding the perspective, yours and mine perspective. So all the ladies and gentlemen who are across the screen, what is our perspective? Do something more. It should have some research element. Do no harm, reproducible outcome, auditable outcome, need to treat. Entity is very important. Don't spend money because they can spend. Patient's perspective, counseling and hand-holding, expenditure is a concern for them. And they want good outcome. And they want a thing which is not totally expendable. We should be actually treating them. Discussing the present traffic lights, applying it to our country, my take would be that these are the various techniques available to us. I just spoken to you about all the techniques. IMSI is red light, so we don't use IMSI. PIXI is red light. We don't use PIXI anymore. It is not to be used. HOS or the mortality technology is green. We can use, we call it HOS testing. ICSI is green. Magnetic sperm sorting is in amber. I'm not very confident about that particular technique. Zeta potential is amber. It is one technique which is going to become green very soon. River density gradient method is green. DNA fragmentation index is actually amber moving to green now. And one technique which we all are using day in, day out is microfluidics. By the patient's demands, and we have to understand that all the patients wants evidence-based treatment. Our technologies are being driven by their expectations, market forces, and online infographics. Pressure from patients and commercial interests are forcing us towards using certain technologies which we should not be using actually. That's what I want to convey to you. So out of these all 6 or 7 techniques which we are using, I think the only technique which is doing us good is sperm selection by any technique which doesn't involve centrifugation. And the ideal technique which we can all adapt is microfluidics. We still have time to discover the new technologies. Just reviewing the Cochrane. Cochrane says that there is no technology which says that one is better than another. And that's the way the Cochrane always works. Cochrane never gives us a proper answer. We have reviewed around 10-15 articles. The only technique which has got potential to come up in a very big way as per Cochrane is zeta potential. Zeta potential and microfluidics we have to watch. There is low quality evidence that hyaluronan binding techniques and ICSI, they give us better rates as compared to ICSI only. There is no other technique which is compared with ICSI or microfluidics, which is giving us a better outcome. So I will like to end my talk. The future is ours. We have to respect the men when they come to us. And I think we should all now gradually move on to the non-centrifugation techniques. And the technique which I have learned in my life, which works very well, is microfluidics. So with this, I like to end my talk. Thank you so much for the patient hearing, and I'm ready for any queries from your end. Thank you very much for the patient hearing, everyone.
Thank you so much, Dr. Pankaj sir. There are words of appreciation for you and for Madam. Amazing lectures, the technology which you have said, and so much equipments and so much work has been done in the last, especially in the COVID times, and the results are really, really good. Jayam Madam, you are also in the same field. You can please go ahead with your expert comments.
I always used to get amazed with Talwar's lectures when I see in the websites, because he used to send his lectures in series, and I have looked at it. I am one of the subscribers for him in yahoo.com. And his today's explanation on the various aspects of these newer technologies in sperm can only be understood by a research embryologist. I don't even think my Dr. Priya Kannan, who was a president of Association of Embryology, could know so much about this mark and other procedures. I used to think about mark in 2000, but as years went on, as I could not see many results, many outputs, I did not take it up. I am one of the person who started with CASA work in India. I purchased the CASA equipment, HVMS. And in the last 10 years, I have understood it is more for research purpose and not for clinical purpose. Clinical purpose still remains the morphology and the motility. And even this size and structure of the sperms, it's amazing that when by Kruger's criteria, they give 3% as morphology, the patient shows pregnancy in the next cycle. Spontaneous. I used to wonder, because I have gone through all these lectures and these Kruger's criteria in 1990, so much I have gone through these workshops, but still I'm really amazed by the constant touch with which Pankaj Talwar wants to express his views on the sperm technologies. Keep going, and the research is really required for us to know why from 3,600 million sperms in the birds, we have come to even accept 36 million sperms in human beings. Thank you very much.
Amazing, amazing, sir. I got words of appreciation. This is Dr. Alpana. She has sent a lot of flowers and heart signs. Excellent. This is Dr. Kanchan Sharma. Very good topic. There is Shakuntala from South India. Excellent presentation. We have got more than 2,573 members who are there.
Oh.
And this is a Diwali bumper. I can say I would like to share with all of you. Sir has got his I seat. He has got the basic to advanced clinical andrology IUI USG courses, and these are hybrid 8 weeks courses, course 1, course 2 and course 3. I am sure the people who have joined, I think more than 551 delegates have registered up till now from probably more than 40 countries. I can see the flags, but I can't identify those flags. And sir, your it's a one-to-one training. A lot of efforts have been done by you, and I think the efforts which you have taken are really gone. There are so many youngsters who want to be a part of learn IVF, learn endoscopy, knowledge is power. Knowledge is infinite. You cannot just be a general obstetrician and gynecologist. And I think you are spearheading it in a very good way, sir. And it's really nice, especially during COVID times. People have really gone back to books and basics, and they have started learning. And this was never before ever. People used to just go to the conferences, meet, and just be a part of few lectures. But things have really changed. And you know, when you are just sitting there, probably in your clinic, or probably in the operation theater, or just outside, or probably cooking somewhere, or maybe feeding your baby around and seeing OPD patients, you just put on this wonderful webinar, just listen to it, and it's amazing. And thank you so much, sir, for being there with all of us. I hope you can see the network is going quite good. Thank you so much, both of you. This is Dr. Naga Sandhya. Pankaj sir is a walking encyclopedia. So it's amazing. Dr. Ranjana, would you like to say something?
Yeah, I would just like to say that Dr. Pankaj, your talk was really very good, and it opened lots of new vistas into this problem, and it was amazing. Very nice.
Thank you, ma'am. Thank you.
So with this, we would like to wind up our wonderful trending task series 9, and I would request now Dr. Stalin to come on and give the vote of thanks. This was the Diwali bumper. We will get back to you after Diwali. Have a good time, but be safe, continue your masking, keep safe distance, and just avoid to be getting infected with any of these problems which we are there. But I'm sure, I think we will not have third wave, but probably we have to be really careful. And it's very proud feeling that India has crossed more than 100 crores of vaccination, and that's why we are all much better off as compared to the other countries. Thank you, madam. Thank you, all of you. I hand over the mic now to Stalin, sir.
Happy Diwali to you and Dr. Jayam and Dr. Pankaj, and happy Dhanteras too, and lot of festivities ahead.
Yes, ma'am. Thank you, ma'am. I would like to thank Dr. Jayam Kannan, ma'am, for your gracious presence and encouraging words. And I also like to thank Dr. Parul sir and Dr. Ranjana Kanna, ma'am, for joining with us this evening in spite of your busy schedule. I would also like to thank Dr. Rishma Pai, ma'am, for that wonderful informative talk and poor responders. Thank you, Dr. Pankaj sir, for your presentation with wonderful features. And Dr. I would like to thank Dr. Chavan sir for your constant support and guidance in making this series successful. Not but not the least, I would like to thank the participants for their active participation. Thank you all. Happy Diwali. Advanced happy Diwali, sir.
Thank you.
Thank you.
For these efforts.